So let's start a new subject, that is orthopedics. So in orthopedics, I have done MS in orthopedics from Shyam Shah Medical College, Riva. Okay, so the topics we will cover in orthopedics is basics about orthopedics, trauma and regional condition, nerve injuries, pediatric orthopedics, joint disorder, metabolic bone disease, bone tumor, bone infection, osteochondritis, spine, and basic bone physiology. Okay, so let's talk about what is in basics in orthopedics. So what are the basics? So there is a concept of nailing, plating, arthroplasty, and arthroscopy. So if you went in a orthopedics ward, ortho ward, you will find 90% patient admitted due to history of trauma. 90% patient if you went in a orthopedics ward. So what is the meaning of it? And in OPD you will find 90% patient is of low back pain. So low back pain is the most common complaint in orthopedics OPD, and history of trauma is the most common complaint in orthopedic ward. So most of the patient admitted in ortho ward is due to history of trauma and fracture in bone. Okay. So what are the topics we will cover? What are the bones we will cover in orthopedics? So let's start from clavicle. So clavicle fracture, then shoulder joint, then arm humerus, then elbow joint, then radius ulna, then wrist joint, then metacarpal, phalanges, then in spine, pelvis, femur, knee joint, tibia and fibula, ankle joint, tarsals, metatarsals, phalanges. So fracture of these we have to see in orthopedics. We did not cover the ribs fracture because that is a part of surgery. So I have written here 90% of operative cases are of trauma, 10% of other disease. So when you went in orthopedic ward, you will find 10% patient are of other disease. It can be osteoarthritis knee for total knee replacement, osteoarthritis hip for total hip replacement. Okay. Now there are two methods of fixation. First is nailing and second is plating in fracture. So orthopedics is nothing, it is just carpenter of human body. Carpenter, what is the work of carpenter? He used to fix gates. Okay, and the orthopedic surgeon is fixed to bone with the help of nailing and plating. So let's assume this is humerus. Okay, this is humerus. Okay, let's assume you are riding a bike and it got fractured from here. So it got fractured here from here. So the condition of humerus will be like this. This is the proximal fragment, and this is the distal fragment. So you can see proximal fragment is this is the left side. Okay, left side. So proximal fragment is going in abduction and distal fragment is going in adduction and medially. So what is the cause of it? Because it has deltoid attachment. So because of muscle pull, both fragment disalign. Okay. So because both fragments are disaligned, now due to fracture in humerus, you cannot take the weight in this arm. You can't take the weight. So what you have to do? You have to reduce this fracture. You have to align this fracture anatomically. So how can you reduce this fracture? By manipulating externally. So this manipulating externally is known as close reduction. You did not give the incision. You have not given incision and you have reduced it closely. So this is known as close reduction. Next topic is what is open reduction. So many a times it has reduced closely, but sometimes it did not, because there can be possibility that fracture fragment are not two. There can be one more fragment from here. So that is known as butterfly. So in that case, it will not reduce closely. So what you have to do? You have to do open reduction. What is open reduction? Give an incision here, separate the muscles by dissecting the muscle and goes till the bone, and then reduce the fracture. That is known as open reduction. Now let's assume you have reduced the fracture by open reduction or close reduction. Now you can't leave that fracture by only reducing, because if you leave that fracture, then there is chances that it can go back in the position. It can again de-align by muscle pull. So you have to fix this proximal and distal fragment by any means. So how can you fix this fracture? By putting nail inside it. You can't leave just by aligning the fracture. You have to put a nail inside it, or you can do plating in it. So what is the plating? So let's assume this is the fracture. This is the fracture of humerus. Okay. Now you have to reduce it. So how can you reduce it? You have reduced it openly by open reduction. Now you can't leave this. So you have put a plate on it and put 3 screw in the proximal fragment, 3 screw in the distal fragment. So you have reduced the fracture and put a plate over the bone and fixed the fracture. Now this bone is fixed with a screw. Now it will not de-align if you leave it also. Okay, now you will ask me that, sir, you have fixed the fracture, but the fracture point is also there. So why we are only just fixing it? Because if you have fixed it and the fracture point are in contact, then it will heal in a year. Body make callus at this fracture point if you align it properly. Okay, so this is known as plating. Okay, so you have understood one thing, that plating is over the bone. So and you have to put screw in the plates. So if you have to put screw on the plate, then obviously you have to do open reduction. So by open reduction and reducing the both bone fragments and putting plate on it and putting the screw, so always in plating you have to do open reduction. You have to do open reduction in plating. Okay, so plating is always open reduction, internal fixation. So why it is known as ORF? What is ORF? Open reduction and internal fixation. Because you can't put screw without opening the fracture site, because plate is over the bone. So because you have to reach till the bone, you have to give incision, you have to dissect through the muscle plane, then you have to reach till the bone and reduce the fracture and put a plate on it. Then you have to drill a screw and tight the screws. So this is known as plating, because you are openly reducing, so it is known as open reduction, and because you are fixing internally, so it is known as internal fixation, and it is known as plating. Okay, now we have learned about the ORF plating. Now let's talk about what is nailing. So आप क्या कर सकते हो किसी बोन को फिक्स करने के लिए? ऊपर से स्क्रू कस दो. Now let's talk about, this is the proximal fragment of fractured humerus bone and this is the distal fragment. Okay, this is proximal, this is humerus, and humerus is fractured from here. So this is proximal fragment, this is distal fragment. Okay, so now you can reduce this fracture by 2 means. You can put a plate over it. Okay, or one more thing you can do is you can reduce this fracture. और इसमें क्या है, यहां से एंट्री करके एक सरिया डाल दो, एक डंडा डाल दो. आई एम explaining you in very layman term, in very easy way, so you need not to remember anything. You just have to apply a simple logic. You just have to apply basic logic in daily life, daily routines. Okay, so what you can do, so you have reduced this fracture closely externally and put a nail inside in both these fragments. So if you put nail inside it, they will not get dislodged, and you have tied the screw here and here. So this is known as nailing. So you have to understand, nailing is inside the bone, inside the medullary cavity. That's why nailing is intramedullary implant. Plating is over the bone. So plating is extramedullary implant. Plate is over the bone. You can see this is the radius ulnar plating. So you can see plate is over the bone. You can see this. And nail you can see inside the bone. It is nailing. You can see nail is inside the intramedullary canal. So nailing is always intramedullary. So that's why it is known as intramedullary implant. Plating is extramedullary. Okay, now you have to understand, nailing could be close reduction or nailing could be open reduction. So one thing you have learned, that in open reduction there is a huge incision. Let's assume this is arm, this is elbow joint, and this is forearm. So this is arm and inside it is humerus. This is, let's assume, humerus, and the fracture bone is fractured from here, let's assume. So you have to, if you want to apply plate in it, so you have to give incision from here, and you want to put a plate on over it at this place, so you have to give incision from here to here, because there are multiple screws. So you have to give this much of incision. So now you have to give 10 centimeter of incision to put a plate. Okay, so in open reduction you have to give large incision. Okay, so huge blood loss in plating. Okay, now let's talk about the nailing. So you have decided that you want to this fracture by nailing. I am telling you, in orthopedics, all the fracture, 90% of the fracture, you have to fix it by nailing or plating. You don't have any other option. Like if someone has fractured radius or ulna, then you have to do plating. If someone has fractured that humerus, then you have to do plating or nailing. If someone has fractured femur, then you have to do nailing. If someone has fractured distal femur, then you have to do plating. So in 90% of cases, you have to do plating or nailing. Okay, there is no any other option left with you. Okay, so now let's assume this patient. So you have understand that in open reduction plating there is a 10 centimeter of incision. Now let's talk about, we have decided that we have to fix this fracture by nailing. So for nailing we have reduced this fracture externally by closely and give an incision here 2 centimeter and make an entry here, put a guide wire in it, then we have put the nail inside it. Okay, so in nailing there is a, and one screw here of 1 centimeter incision, one screw here for 1 centimeter incision. You can see in this patient there is a one screw here, one screw here. So, and we have made an entry from here. Okay, so you can see there is a very less incision in close nailing. Okay, but many a time the fracture did not reduce closely by manipulating outside, so you have to open that fracture. So many a times you have to open that fracture क्योंकि सामने तो आ जाएगा, तो open करके you can reduce manually. Are you understanding what is close reduction and what is open reduction? Close reduction mein we did not give incision and reduce the fracture externally. Are you getting my point? If someone get fractured is humerus, then we can manipulate the both fracture fragment from outside. This is known as close reduction. If in some patient it did not get reduced, then we have to give incision and reduce it openly, incision, and then reduce both fracture fragment by bone holding. Okay, then we will do nailing. So nailing could be close reduction or open reduction. First we will try close reduction. If it did not get reduced, then we will do open reduction. Okay, plating is always open reduction because plate you have to apply over the bone. In nailing we can make an entry and put nail inside it, so we did not need to open the entire fracture site. Okay, so in nailing if it is close reduction, the blood loss is less, so we will try for each patient then that we can fix it by close reduction. If it did not possible, then we will go for open reduction and nailing. Okay, so these are the concept of close reduction and open reduction and nailing and plating. Okay, so close reduction, less blood loss, less incision, fracture, hematoma is preserved. Okay, nailing, first we will try close reduction, then open reduction. Okay, now let's talk about the open reduction and plating. So in plating there is always open reduction. We will apply plate over the bone and multiple screw. There is only two method of fixation. Okay, open reduction or close reduction. Okay, and mostly we have used implant in 90% of cases, nailing or plating. Now let's assume there is a fracture in metacarpal. So in metacarpal we did not place nail or plate because metacarpal is very small bone. So let's assume this is the first, second and third metacarpal, fourth metacarpal and fifth metacarpal. Let's assume it got fractured from here. Okay, and the fracture got displaced like this. So what we have to do, we have to reduce this fracture. We have to align both fracture fragment and we can put a K wire inside it. You need not to put an itni badi nail, you need not to fix, need not to fix by nailing. So that's why I have said that 90% of cases you have to fix by nailing or plating. In 10% cases it could be hemiarthroplasty, it could be K wire, or there are new implants available, like there are many new implants available. Okay, now 90% cases two view is used, that is anteroposterior view and lateral view. So you can see in this patient there are two plates, one over radius, one over ulna. Okay, so you can see this is the anteroposterior view. Okay, X-ray rays going anterior to posterior, this is anteroposterior view, and this is, you can see, lateral view. Okay, like in this case also you can see this is anteroposterior view of nail, this is lateral view. Lateral view is X-ray radiation is going lateral. Okay, now the basics of any fracture fixation. Try for close reduction, I have explained to you. Align the fracture anatomical, explained to. If did not align, then go for open reduction, I have explained to you in the nailing. Okay, we have learned about the extramedullary and intramedullary implant. Now there is a concept of arthroscopy and arthroplasty. Okay, so what is arthroplasty? Arthroplasty is replacement of joint. Let's assume we have fan in house. So fan has a lifespan of 10 years. Okay, fan has a lifespan of 10 years and we have to replace then that fan after that because वो खराब हो गया. Okay, everything has a life span, है ना, कुछ सब कुछ खराब होती है. Let's assume you have purchased a new car, then after 10 years you have to discard it because there are so many technical error in or mechanical error in car. Okay, let's assume you are born, so you have so many organs, liver, kidney, knee joint, and also there are so many joints, knee joint and elbow joint, ankle joint. Okay, so and you have born, and at the age of 1 year you start walking. So you are putting all your weights on your knees since 1 year of age. So 1 year, then you are 10-year-old, then you become 30 year, then 50 year. So you are walking since 1 year, and your knees are you are walking on your knees since 1 year. So now you are 60 year of old. So knees are 60-year-old. So knees are lifting your old 60. Knees are होल्डिंग योर वेट सिंस 60 ईयर. तो उसमें भी तो कुछ खराबी आएगी ना कि लाइफ लॉन्ग चलने वाले हैं नीज, घुटने. तो क्या होता है, दीज आर द फीमर, दिस इज टिबिया. सो बिकॉज नीज आर लिफ्टिंग योर वेट सिंस 1 year of age, so it got arthritis. What is arthritis? Degenerative changes. So osteoarthritis, I will not say it is a disease. Graying of hair is not a disease. It is a normal process. Presbyopia is normal. That's why same as osteoarthritis is normal, because osteoarthritis degenerative changes in knee joint. So knee joint had degenerative changes. There is a reduced joint space. Reduced joint space because of degenerative changes. And degenerative changes is not seen in 30 year of old patient. It is seen in old age. 30 year में नी को कुछ नहीं होता. कार को 1-2 साल में कुछ नहीं होता. 5 साल 10 साल में होता है. नी को 50 साल 60 साल में होता है. Are you getting my point? So this is degenerative changes in knee joint. So let's assume your grandfather, which has 70 years of age, has femur and tibia like this. There is no any joint space left. This is known as severe osteoarthritis. So you went to an orthopedic surgeon and he said that we have to replace this knee joint. So what is the replacement of knee joint? Because it has osteoarthritis. So what we will do, we will cut this distal femur and this tibia part and replaced with implant. So the pain because of this severe osteoarthritis will go. This is known as replacement of knee joint. It is known as total knee replacement, popularly known as TKR. So because you are replacing this knee joint, this is known as arthroplasty. After doing MS orthopedics, many people have done fellowship in arthroplasty. Okay, so you have understand what is arthroplasty, replacement of joint. You can replace the hip joint also. That is known as total hip replacement. We will do hip replacement in osteoarthritis hip. Okay. So next is arthroscopy. What is arthroscopy? Arthroscopy is, scope is a camera. So let's assume this is femur, this is tibia. Let's assume these are the two lakadis. So have you ever imagined why these lakadi are not going aage piche? You are walking, you are running on femur as well as on tibia fibula. So have you ever imagined that I am running, but still, because these are two different lakadi, na? This is not a single lakadi. Because at knee joint you have to flexion. If it is a single lakadi, then you can't do flexion at knee joint. So you know that there is a femur and tibia and both are different bone, and you are doing flexion and extension at knee joint. So have you ever imagined that I am walking, running, but still these are in place, and these are two separate lakadis, na? These are two separate bones and one over the another. So there could be a possibility that you are running and femur can go anterior or tibia can go posterior, but they did not go. Why? Because there are so many rassis here, so many ropes here. These are known as ligaments, like MCL, medial collateral ligament, LCL, lateral collateral ligament, ACL, PCL, anterior cruciate ligament, posterior cruciate ligament. So let's assume there is an athlete and Carolina Marin is a badminton player who has won the gold medal in 2016 and 2020, but in 2023 Paris Olympic, he has to go in between the match because he has torn his anterior cruciate ligament during the match. So this is anterior cruciate ligament. Okay, so you have to do arthroscopy because ACL ligaments, what you have to do, you have to put a camera inside it and repair that anterior cruciate ligament. That is known as arthroscopy. Okay, So it is a minimal invasive procedure to examine the joint, examine the knee joint, or repair the ligaments inside the knee. That is known as arthroscopy. Next is splints. What is splint? Splints first is slab. Let's assume this is radius, this is ulna, this is wrist joint, multiple carpal bone. Some patient has fractured the radius and ulna and came to you. So what will you do? So because these fractured and both the proximal and distal fragment irritating the nerves near to it. So because it is irritating the nerves near to it, patient will have severe pain. So what will you do? You will immobilize those fragments. So to immobilize this fragment, you will apply a slab. Slab is POP, partial cast. You will not apply the cast into the entire forearm because after fracture there is a swelling. So swelling may cause compartment syndrome. So you will not apply cast, you will apply slab. So you will give a room for swelling to progress. So that's why slab is partial cast. Okay, so you will apply a slab for temporary stabilization the fracture because you have to operate this fracture, you have to put a plate on it. But patient is in severe pain. आज पेशेंट आया, आज तो ऑपरेट नहीं होगा बिकॉज इन्वेस्टिगेशन कराने पड़ेंगे, आपको प्लेटिंग करना है. Now let's say the patient came in your OPD with radius ulnar fracture and you decided to operate this patient. Okay, so you can't operate तुरंत तो आप ऑपरेट कर नहीं सकते. What you have to do? You have to do investigation of that patient, that is CVC is normal or not, hemoglobin is normal or not. But so you have decided that you will operate this patient tomorrow. Now patient, how will you patient bear that pain for one day? Because it is severe pain in bone fracture because both fracture fragment will irritate the nerves near to it. So what will you do? You will apply a slab that cause immobilization of fracture fragment. So patient will have pain relief. So this is the first use of slab. Now what is the second use? So let's assume this is the radius, this is ulna. Okay, so patient had got fractured here, but fracture fragment did not de-aligned. Fracture fragment is in place. So what will you do? So you will do movement at wrist joint. So there could be a chances that you can dislodge these reduced fragment. Many a times we have seen patient in OPD that there is a fracture. Undoubtedly there is a fracture, but it did not displaced fracture. It is undisplaced fracture. Both fracture fragment are in aligned, but there is a fracture. So what will you do in this case? You have to immobilize those fracture fragment. So for those cases, we will apply a slab. Okay. So you can't do movement at wrist joint by applying slab. So if you can't do movement at wrist joint, the fracture fragment will not disalign. Okay, de-align. So this is slab. Now what is cast? So we have applied slab. It is partial kind and we have given room for swelling. Now after 7 days, swelling is subsided. So swelling is subsided. So we will apply an encircling cast which is covering the entire circumference of forearm for radius ulnar fracture. Okay. So cast is applied after 1 week. Okay. Next is boot and bar. So boot and bar is applied for intertrochanteric fracture. So what is intertrochanteric fracture? This is femur. This is femur. This is greater trochanter. This is lesser trochanter. This is the fracture line. So after fracture, the position of both fragment by like be this. This is the fracture fragment and it goes upside. So it causes the pain to the patient. So we will apply a derotation bar here. So because of derotation bar, the limb will not rotate. So patient will have relief in pain. Okay. So that's why we will apply boot and bar for intertrochanteric fracture. Next is Thomas knee splint. It is used for stabilization of femur fracture. Let's assume this is the femur bone. It got fractured from here. The fracture fragment will be like this. Now the patient is 20 kilometers away from the hospital. So you can't bring this patient to the hospital because it will have severe pain. Or there are chances of fat embolism in femur fracture. So you have to immobilize this fracture fragment. So you will apply a Thomas knee splint. This is the Thomas knee splint you can see. This is the Thomas knee splint. So you will immobilize this stabilization fracture fragment. Okay. Next is BB splint. It is used. You can see this is BB splint. It is used for proximal tibia fracture. Okay. Okay, BB splint is used in proximal tibia fracture. There are so many pulleys and you will apply a weight to it for traction. Okay. Next is pelvic fracture. So in pelvic fracture, there is huge blood loss. So we will apply a pelvic binder. Pelvic binder will compress the pelvis and it helps in pelvic tamponade. Okay. Now, what is the concept of open fracture as well as closed fracture? So patient is present with fracture of femur with no any wound over the skin. So this fracture is known as closed fracture. Now patient with present with fracture along with wound over it. So this is known as open fracture. Okay. Now what is crush syndrome? It is myonecrosis of crush limb. Patient present with crush injury. So there could be a myonecrosis. This is known as crush syndrome. Now the various type of cast. Below elbow cast. What is below elbow cast? Let's assume this is forearm, this is arm. Okay, this is elbow joint. So the patient has fractured a distal radius. So this is the fracture point. This is radius ulna. This is hand. Okay. So because the patient is fractured at here, so and it is undisplaced fracture. So you have applied slab for 7 days. Now you are planning for cast. Now you have confused that I have to apply below elbow cast or above elbow cast or what type of cast. So in distal radius fracture, so you have to just immobilize the wrist joint. You need not to have immobilize the elbow joint because wrist movement can dislodge the fracture. So just apply a below elbow cast 5 centimeter from olecranon and the knuckles of hand. So this is the length of below elbow cast. Now let's assume it is not a distal radius fracture, it is the mid shaft radius fracture. So in case of mid shaft radius ulnar fracture, you have to immobilize the elbow joint as well as wrist joint. So to immobilize both, you have to apply the cast at above elbow because you have to immobilize both. So cast is applied to immobilize the joint and make the patient pain free. Okay. Next is below elbow, below knee cast. Same in metatarsal fracture. You will plan for below knee cast. Let's assume patient has tibia and fibia, proximal tibia fracture, which is undisplaced. So you are planning for conservative management. So for conservative management, you can apply a above knee cast because you have to immobilize the knee joint in proximal tibia fracture. So to see which type of fracture is this, you have to apply the cast according to that. You have to immobilize the joint above and below to the cast. Okay. So cylindrical cast is used in patella fracture. One thing you have to remember that cast and slab is applied. Cast is applied for those patients we are managing it conservative. Let's assume there is a this is tibia and patient has fracture at this level, but it is undisplaced. So we will not go for plating or nailing in this patient because the fracture is undisplaced. Why we will give incision if fracture is undisplaced? It will heal by itself. It will heal. Body will heal itself. We have to just immobilize those fracture fragments so that it will not get dislodged. So you have to just apply a Babni cast in this patient. Okay. Now the figure of 8 bandage, it is used in clavicle fracture. So you can see this is the clavicle, this is the clavicle, this is face. So it got fractured here. So fracture fragment will be like this. Okay, this is right side, this is left side. So fracture fragment will be like this. This is lateral, this is medial, this is right side. So you have to just apply a figure of 8 bandage. So those fracture fragment will align. Or it can be malunite. It does not affect the mobility of shoulder joint. So figure of 8 bandage is used in clavicle fracture. Now let's assume external fixator. What is external fixator? So let's assume there is a patient who came with femur fracture along with wound of 5 into 5 centimeter, which is deep wound. So you cannot put a nail inside this femur fracture because it cause. If you put, let's assume this is thigh. It has wound here. This is the femur fracture, proximal fragment. This is the distal fragment, and there is a wound it. So you can't put a nail inside it if the patient has wound because it can infect that implant. So what we will do, we will externally fix this patient by putting pins. So you have externally fixed this patient, externally fixed the bone, and so you have immobilized the both fracture fragment. There is a wound. So after applying external fixator, the wound will heal. So wound will heal. After wound healing, you can put a nail inside it. You can't put implant in patient who has open fracture. You have to wait for wound to heal. Then you can put an implant inside it. Otherwise, it got infect 100%. Okay. Now the principle of amputation. So what is amputation? What is amputation? Amputation is discarding of useless affected soft tissue and bone. Okay. So how will you decide the level of amputation? So let's assume there is a patient who has injury at the shoulder level and he has axillary artery injury. So and he came presented to you 3 days later. So because he has axillary artery injury and presented 3 days later, so the blood supply will gone for the upper limb of left side. So it will goes in necrosis because blood is the supply for the oxygen of tissue. So it will Supply of oxygen will lost to the entire limb, so patient will have necrosis with gangrene. So because the injury at the shoulder level, you have to do shoulder disarticulation. Shoulder disarticulation. So the level is decided where is the injury. So if the patient has injury in mid forearm, so because injury is at mid forearm, you will decide for below elbow amputation. Injury is at elbow joint, so you will decide for elbow disarticulation. We will try to preserve the maximum bone. Okay, amputation is not good for patient, but it is the necessity in case the to save the life of patient. Okay, so there could be so you can decide the level at your own convenience. Like the patient has crushed injury at mid leg, and you can't survive the affected limb. So what you have to do? You have to do amputation to save the patient life. So what we will do? You will do below knee amputation. So there are various types of amputation you can see, and you can decide it. I have explained to you how you have to decide. Okay. Now there are three types of amputation: Sims amputation, Chopard, and Lisprank. And we have done amputation also in patient who has Berger's disease. Berger's disease is gangrene due to smoking. Okay. So Chopard amputation is intertarsal and Lisprank is tarsometatarsal. Now there are two types of foot. So let's assume you have done a above knee amputation of a patient. Okay. So this is above knee amputation. This is left side. This is right side. Okay. You have cut the bone from here. Okay. So now how will he walk? So you will apply a prosthetic limb to this patient, but you have to give Sach foot or Jaipur foot to this patient. Okay. Because there are so many movements at ankle joint or subtalar joint. To movement for subtalar joint and ankle joint, you have to give Sach foot or Jaipur foot. Okay. So Jaipur foot looks like normal. Patient walk barefoot. Can we walk barefoot? Dorsiflexion inversion is possible. It is cheap. Okay. So, and Sach foot does not look like normal. Dorsiflexion inversion absent. This is Sach foot. This is Jaipur foot. Okay. So in prosthetic limb, we have to give a foot. We have to give foot which is more convenient, which is cheap, and which can do all the movements at foot joint. Okay. So this is the end of basics of orthopedics.